So I wanted to make the film because I had an experience with chronic pain when I was 22 years old. I had developed chronic tendinitis and a repetitive stress injury that I believed was from lifting weights at the gym, going too hard, maybe playing guitar and typing too much on the computer. I saw many different doctors. I tried physical therapy. I was put on opioids. I tried eating more, as one doctor recommended, just eat more. And none of those things worked. And I was really depressed. I had to drop out of college, and I sort of was disabled and didn't know what to do. Then I read a book by Dr. John Sarno called The Mind-Body Prescription. And in the book, he explains how the body has great capacity for healing, and that when chronic pain persists after 8 months or a year, it's very unlikely it's due to an initial injury. That injury is likely to have healed. And when the chronic pain remains, it's much more likely that it's a brain-induced or a neuroplastic pain process. It can be caused by stress, it can be caused by trauma. In my case, I think it was mostly caused by fear of injury, fear that this pain was a sign of damage to my arms, and then a kind of fear avoidance, snowballing effect that I had. And after I encountered those principles, I got better the next day. My pain, I was able to type on the computer, my pain went away, and I was just totally blown away. And 10 years later, I wanted to make a film because I was so curious, can this treatment work for other people? Is it possible that this is a future for better chronic pain treatment? And Marion and I went and filmed with Dr. Howard Schubiner, who's based in Detroit, Michigan, who you saw in the film. And the result is the film, This Might Hurt. And so my first question is going to be for Dr. Koushik. Could you talk about what made you want to bring the film to USC?
Yeah, definitely. So at USC, basically we work at a kind of a tertiary academic medical center. So a lot of the patients that come to our pain management clinic are people who have been out in the community. They've had lots of different procedures, been on opioid medications, neuropathic medications. They've tried a lot of different things to manage their chronic pain, and usually they're getting exhausted because most of it isn't working. So we do deal with quite a few of these types of patients, and we offer a ketamine infusion program here as well, which is not really offered out in the community. So I think we may be sought after for that reason. But I was just looking essentially for other alternatives or options for these patients, kind of trying to discuss maybe the feasibility of having a program like this at a major academic medical center, because I know it's quite not really a mainstream therapy yet, and not something you hear about very often. So I see a lot of patients with these types of diagnoses that are mentioned in the film that are frustrated. And that was sort of my motivation for bringing the film to USC, to at least get the discussion going on how to maybe incorporate a program like this at our center.
That's so great. Yeah, thank you for reaching out and making this happen today. We're so excited to be here. Marion and I worked for 7 years on this film with the exact goal of talking with groups like you guys and saying, is there room to improve care for people with chronic pain? And our experience making this film made us feel like definitely there is room for improvement, that there is these new evidence-based therapies that have really powerful principles that can be integrated into many different ways of approaching chronic pain. And that leads me to a question for Dr. Stracks. Dr. Stracks, what led you into doing this work, and how do you kind of talk about what you do?
So I had essentially a conversion experience like you did, where I had the chronic symptoms that nobody could figure out for 9 months, and was just getting worse and worse. I'd actually read Dr. Sarno's book before, and I was talking with a friend who had snuck into Dr. Sarno's office for an evaluation, and it has back pain go away. And so I reread it, and same thing, within a day had gotten significant relief that hadn't happened in the previous 9 months. And this was all on my way to medical school. And so I was in the process of trying to get in. I had a different career. So I was in my late 20s at the time. I was dating the woman who is now my wife. And so I was stressed about sort of that relationship going on. And I was having a spiritual crisis as just on top of all of it. And so it was too much for my nervous system to manage all at once. But when I was able to put it together, I got better very quickly, and then went to medical school a couple of years later with the express intent trying to learn as much as I could about this. And so I've studied with Dr. Sarno. I did my residency at the University of Michigan. So I spent a lot of time with Dr. Schubiner teaching the classes that were the precursor to what there was in the movie, and then opened my own center 5 years ago to continue to offer this kind of treatment to as many people as would like to come and see us.
Awesome. Dr. Koushik, could you talk a little bit about what it's like for you in terms of, you're saying that you see a lot of people from the community who have tried pain medicine, I guess that you call the standard or the typical treatments that are offered in pain medicine. I know you also do ketamine, which is more unusual. What are the kinds of challenges that those patients face, and how do you make sense of them?
The main thing I would say is a lot of people don't have a clear-cut diagnosis when they come to us. And so you get this kind of, widespread diagnosis of fibromyalgia or CRPS, which is thrown around and may not necessarily meet the criteria for these specific diagnoses. But fibromyalgia has almost become, we have some kind of pain, we can't really figure it out. We're going to give you this diagnosis and we're going to, send you somewhere that can hopefully help you. So I think you deal with a lot of frustration from patients in that sense, and that nobody can figure out or pinpoint or even take the time to explain like central sensitization to them. The other thing is that there's a lot of ongoing psychiatric comorbidities usually that I find with these chronic pain states. And a lot of patients haven't really been told about this or really even been involved in any type of psychotherapy or received any type of psychiatry care when they come and see us. So we're often the first person that they see that can even direct them, to the right place and try to explain potentially the mechanism behind why they've dealt with chronic pain for years or decades.
Yeah, wow. Yeah, as somebody who had chronic pain, I had a definite comorbidity, though I didn't use that word. I was depressed, I was anxious. I had moments of being suicidal because I had never been depressed before the pain. And I think that's an interesting thing, in this dialogue around chronic pain. A lot of times people say like, oh, their chronic pain is just a result of their psychiatric problem of depression or anxiety, which is not accurate. Like, for example, or it can be sometimes, but in my case, for example, it wasn't. I had no depression, I was happy, I got pain, and then after a few months, I became depressed. And so anyway, this question of chronic pain as a psychiatric problem and this mind-body divide, I think is so interesting. Obviously, that's what, those are the questions that drive the film, is can you separate these mind-body things, and when do you separate them, understand something as a pathological problem of tissue damage, and when do you understand it as more of a mind-body interaction that's complex. Anyway, I'm going on and on. But Dr. Stracks, I wanted to ask you sort of, when the patient comes in for you and says, oh, I was diagnosed with fibromyalgia, it's this thing, I'll have it forever, or I have CRPS, I know it's incurable, and I'm really worried, and I've tried everything. How do you help a person with these very scary diagnoses that are so common now?
One thing to note about fibromyalgia, so when I was in Michigan as a resident, Dr. Schubiner and I started a study with a rheumatologist who ran a fibromyalgia clinic. And it was my job to interview the patients. Study never got published because the data turned out to be kind of overwhelming. But part of what I did was use a structured trauma interview with these patients. And when I started asking these fibromyalgia patients what had happened in their life, they went on and on and on and on about these traumatic experiences that happened to them as children and as adults. And I think it was an overwhelming experience for me, which is why we didn't know what to do with the data and didn't publish it. But that always sticks in my mind when I see a patient with fibromyalgia, that I know that there's at least a possibility that they have this history of traumatic experiences in their past. And so when someone comes in to talk with me, we spend a lot of time talking about how pain forms in the body and what the nature is of the relationship between the body and the brain. And that our intuitive experience is that if we hurt in our body, there must be something wrong with our body. But the science at this point in the 21st century doesn't really support that. The science supports this idea that the pain is being generated in the brain for a variety of reasons that have to do with danger and safety. And when I outline this for patients and say, we don't need to look as much about what's happening in your body, but what's happening in your life, and what can we do to start to change and heal some of those experiences. And that's how people start to move forward and feel better.
That's really, go ahead.
One question for Dr. Stracks. How do you manage patients, either patients or other physicians who are very skeptical of this type of therapy, and don't think that it's going to be effective, or even maybe patients who start working with you and then midway through, they start to give up or are really, kind of cautious or suspicious of the whole thing?
Sure, and there's I run groups like the ones Dr. Schubener was running in the movie, and I'll point out frequently, like, we might have 10 people, 12 people. I'll say there's 100 million Americans who have chronic pain. You'll notice that not all 100 million American or 100 million of those are here in these groups. My situation now is a little bit different, right? I worked in the big hospital system at the University of Michigan and Northwestern Hospital, and then set up my own practice. So these days, a lot of people come to me already having heard about this. When I was at the hospital, I would bring up the topic pretty gingerly for people. And so I was in the Integrative Medicine Center. People were looking for alternatives. I might say, there's lots of things that we can do for pain over and above medication. And so you can see our acupuncturist, or we can talk about your diet, or we can work on the chiropractor, or we can think about the connection between mind and body. And if people were interested in that, then I would get in a longer discussion. And so one of my patients who's done really, really well with chronic migraines, she recounts having had that precise conversation. I got to the mind-body connection part. She's like, I want to learn more about that. What can you tell me about that? And so I tend not to push super hard on people who are really skeptical. And like any new concept, you may need to hear it 10 or 50 or 100 times before you're ready to latch onto it. And so I've got patients who saw me initially in Chicago in 2009 or 2010 who called me in 2017 and 2018 and said, hey, I think I'm ready to discuss this. And so it's just planting seeds, and some people are ready and some people aren't. And I really work hard not to push somebody into a place where they don't really want to go. And so that's what I've tried to develop over time. Who wants to learn more, and how can I gradually give them more information, as opposed to try to shoving information on people who really came in to get a medication or an infusion. And so this is just a new concept that needs some time to percolate and to develop with them.
Then just on that, and this maybe a tough question to answer, but what percent of your patients would you say have a meaningful pain reduction for them? And do any people have recurrence of pain after they finish your program?
Yeah, and so I would say we probably are in somewhere the 50 to 70% of people who are coming in having learned about this, wanting to do it, wanting for this kind of treatment to work. And so we get a lot of good response. And, Dr. Schubiner's fibromyalgia studies was a third of patients got almost completely better, which is unheard of in the fibromyalgia literature, and made it difficult to publish the studies because people didn't believe the results. And then another third got significantly better. So 2/3 of people with fibromyalgia having significant relief with this kind of intervention. What I say to people about recurrence is that, because pain, I don't think of as a disease, a separate disease, the way I would say strep throat is a disease. So if somebody comes in my office with strep throat, we test them, we figure out what it is, we give them penicillin, and then they're fine. They may never get strep throat again. But I don't think of pain necessarily as that. I think of pain as the way our body expresses what's going on in our lives. And so what I tell people is that getting better doesn't mean that you're not going to live your life. It doesn't mean you're not going to run into stressors again. It doesn't mean that the pain won't potentially pop up. What I'm hoping for people is that when the pain pops up, they have a really nice model for what it is and how to deal with it. And so it's not that they won't live their lives and run into stressors and difficult situations and hard emotions. But when they do, they won't necessarily go back to like, oh, what's wrong with my leg? I need an MRI. It's what's going on in my life and what can I do about it so that if my leg doesn't have to express this for me anymore.
I wanted to, Dr. Stracks was mentioning working with therapists before we started our conversation today. And then Dr. Koushik, you mentioned also that you've been trying to figure out how to get chronic pain patients who have never been offered or suggested therapy for some of their comorbid psychiatric problems, therapy. And so let's talk about that for a second, because as we know, sometimes what happens is a chronic pain patient goes in hoping to get treatment for a physical ailment, and then somebody says, oh, I'm going to send you to a psychiatrist, and then the chronic patient is like, F you, I hate you so much, you're not validating my pain. And so that's a real risk for doctors who think that their patients need psychotherapy, may even think their patients could benefit from something called pain reprocessing therapy or emotional expression therapy for their chronic pain problem. But so how, maybe I'll start with you, Dr. Stracks, like, how do you do like a warm handoff where someone sees you and then you kind of walk them into the therapist's office and it's a behavioral health, type of thing? Or do you have a different system? And how do you recommend for doctors who are interested setting up simple ways for people to not feel stigmatized, but to incorporate behavioral health considerations for evaluating chronic pain?
I think, at this point we have 3 psychotherapists and are likely to hire more who work in our practice. And so, a lot of practice is virtual these days, so we don't walk down the hall anymore as much as we walk down the Zoom line. But I will, when people come in and they want to talk about this, and we're talking about various options, there are times when I think that there's enough that they can do on their own that I'll say, here's, I think, some reading material for you. These are the kinds of exercises that are helpful for people. Here's a meditation app that I think would be really useful for you. And some people are able to take that and really run with it. There are other people who either are struggling or they've got some significant psychology or anxiety or depression underneath. And for them, I'll say something along the lines of, I've seen a lot of people in your situation, and for a number of them, talking with a therapist, and we've got really good psychotherapists, has been really helpful to work out a couple of these aspects of what's going on to really address the anxiety in a meaningful way. And let's get you set up with one of them for a consultation. And so I try as much as I can to normalize it, to destigmatize it, to not make it seem like it's anything other than this is the next step towards feeling better. My colleague David Clark in Denver, who's a gastroenterologist who does this work, says he's been able to boil it down, I think, to 9 words: stress causes real pain, effective treatments are available. And so that's, I think, really what we're trying to get at, is that we want them to be better. We think that this is a significantly likely way that they can be better. It's different than what you would imagine. It's different than what you think of as medicine, but it has been shown in studies to be highly effective. And that's kind of the nature of the message that I'm trying to deliver.
Yeah, I guess I just want to add, when I was filming people with chronic pain and talking to a lot of patients in going into different practices, some were mind body, some were non-mind body, I just took in this idea that patients really look to doctors as authorities, and they listen carefully and they take advice seriously most of the time. And so if a doctor can very carefully explain the new neuroscience that shows that the brain can cause pain, that stress can cause real physical pain, that in a non-stigmatizing way, I think a lot of patients are maybe more open-minded than some doctors might think.
Yeah, and I think that, one of the big luxuries that I have in the clinic I've set up is time. And so I have time to unpack the story, I have time to listen, I have time to make a connection. And the horror stories I hear from my patients about kind of what the judgment they get in the medical system or the dismissal they get. And so I work really hard on that aspect too. And, at least once a day, somebody say, I know this sounds crazy. And I say, like, there is no crazy. Nobody in our practice is crazy. Everybody's trying to get better. Everybody's trying their best. And so really to sit with patients, to respect them, to try to give them the sense that I'm on their side, that goes a long way. And I know that not everybody can work in a clinic or a center like mine, but I also know that when I was at the hospital and, I was in the integrative center, but I would do urgent care once a month for the hospital. And just stopping, and a patient came in, they had a sinus infection, and wrote the prescription for antibiotics. I said, sometimes sinus infections happen when we're stressed, anything going on. And he had just lost his job. And we talked about it maybe for 2 minutes, maybe for 90 seconds. And then I walked him to the door, and he and his wife could not stop talking about how kind I was, how gentle, how caring. It's like 90 seconds of investment makes a huge difference. And the medical system runs so quickly that like 60 to 90 seconds of just stopping, listening, sort of honoring what people are saying can make an enormous difference in people's experience.
Thanks. Yeah, that's a great point. We have a question in the chat from Brandon. Brandon, if you are able to unmute yourself, you can ask it directly yourself. Feel free to come on camera too if you want. If not, I'll ask your question for you. I'll give you a second.
Yeah, thank you. So pretty much just wanted to ask Dr. Stracks, your experience so far. I know that the pain can manifest in a bunch of different ways with a lot of your patients, but I was wondering if you personally observed some sort of association between types of trauma and certain types of pain, whether they manifest in a consistent way at all.
I think so. One interesting experience I've had is that I wrote a handout about migraine headaches for my patients and in a mind-body standpoint. And then I finished the handout and I thought, oh, well, this is great. Now I've got 30 handouts because I can just like search and replace migraine headache and put in back pain or neck pain or fibromyalgia and make it a new handout. And so I did that, and the handout no longer worked. And so the characteristics of my patients with migraines are a little bit different than the characteristics of other patients with other types of pains, not always even in a way I can put my finger on, but in ways that like you can't just substitute one for the other. I gave the example of fibromyalgia. And so I've seen patients with just repeated chronic and complex trauma who present with the fibromyalgia and CRPS type diagnoses. You may have been referring to, like, is there a history of sexual abuse? Will that come out in pelvic symptoms, which I think oftentimes pelvic or abdominal symptoms can be associated with those kinds of traumatic experiences. And I'm thinking about, more short-term, discrete, like bicycle accidents or car accidents. You tend to see it in the skeleton and musculoskeletal symptoms. And so there's some of that, obviously not always, but there can be some consistent characteristics depending on people's experiences.
Great. Thank you. Let's.
Sorry, follow-up question.
Oh, go for it. Yeah.
So let's say, you have a patient presenting with these symptoms and, there's nothing that they could find, but when it comes down to the conversation about trauma, they have nothing to share. They're, essentially saying, oh, I can't think of any traumatic experience like that in my life. What do you do at that point? How do you approach that?
So I think that the way my reading of the literature at this point and of the science is that pain is a response from the brain in response to actual or perceived danger. And so the most obvious way that works is if if we finish this and I get up and I trip and I break my leg, I don't want any of you to tell me just to meditate and I'll be fine. But B, I want the pain there because I want to know that there's something wrong. I need to get to the hospital, get an x-ray, get the bone fixed. And so we normally think of this in terms of physical danger causing the sensation of physical pain. But it turns out that danger takes all kinds of forms that don't have anything to do with our physical body. And so these traumatic experiences and the memory of them can be dangerous and can be a reason that pain shows up in our body. But less traumatic stressors or workplace situations can feel dangerous to people. Relationships can feel dangerous to people. Emotions can feel dangerous to people. And so we have all these experiences as human beings. And if we're super psychologically healthy, then maybe we express it in words and feelings instead of physical symptoms. But most of us are not. And so most of us tend to express our day-to-day lives in our bodies. And so the trauma is one aspect of it, but I'm also trying to get a sense of how do people live their lives? What's their psychology like? How comfortable are they in the emotional realm? What are their relationships like? And so I'm always looking in those areas to see if I can see an entree point for the discussion. If all else fails, if they're like, nope, 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 everything perfect, just the worry about the symptoms themselves can keep the symptoms going. And so just that is enough to perpetuate it over time. And for some of my patients, that's really what they need to work on, is this fear of the symptoms themselves and how to calm down that worry in their brain.
Thank you.
I think we may have I see a hand raised.
Yes, Fatima, please unmute yourself.
Thank you so much. Hi, everyone. I have first a comment and then a question. And my comment is really more of an acknowledgement. I wanted to thank and acknowledge all of you. First of all, Kent and Marianne for the movie. Yeah, my feeling was this optimism and excitement when I saw the movie, and really the content of the movie and the message of the movie. I'm currently a graduate student at USC. I'm getting my PhD in epidemiology, and actually I choose to focus on mind and body practices type 2 diabetes specifically. And I just completed a meta-analysis looking at the effect of mind and body practices, which the findings were actually really incredible. I was not even expecting that myself, and I'll be presenting some of that work at the International Congress for Integrative Medicine and Health in May. So with all that said, it's really exciting for me to you just see the initiative of Dr. Koushik and Dr. Stracks, what you're doing, and having it be like more like out there and translational and practical for people. So thank you for that, for the movie, and thank you for today. I've been learning a lot just listening. Now my question, right? So there was a comment in the movie, and I don't remember who was it, but one of the MDs said that there is there's those people who think that when it comes to like chronic pain and unexplained or undiagnosed chronic pain, there's those of probably those who are more like me who think that, oh, it has mostly some kind of mind and body connection, and there might be other pains that don't. And that we may think that the majority is like mind-body connected. And then he had this argument that no, he thinks that it's actually it might be the opposite, where there may be few people for whom their pain is more mind-body connected. And then, but for most people, you can't explain it as such. So since I'm not an expert in the literature, my question to you is, do we even have any sort of like empirical evidence out there about that in the literature? And how much of, so far in terms of like work research, can we say that chronic pain has a sort of like correlation with mind body? And if the work hasn't been done, because it just may not be out there, what do you think?
So does Dr. Claw, I believe, who's the fibromyalgia lead at the University of Michigan, and interestingly has collaborated with Dr. Schubener on a number of studies, and somebody who I knew peripherally when I was there at the university. And he's actually remarkably, and Kent, I don't know what your experience with him was, he's remarkably supportive of this aspect of medicine. He's also very grounded in sort of the genetic aspects of fibromyalgia, and I think comes from a very biomedical background, and so that's his leaning. I think a lot of the research that's been done in this area has been done actually here in Chicago at Northwestern by Dr. Apkarian and his lab, and they've done a lot of studies that have shown that brain activity in states of chronic pain really gets chronicified quite quickly when the pain is there for more than about 6 weeks. And so I think that's where we take some of our knowledge that that the experience of acute pain is different in that sense than the experience of chronic pain, and it doesn't take that long in order for it to enter there. And so, for instance, in their back pain studies, their conclusion was that about 90% of the experience was brain driven as opposed to back driven. And that's language that I use frequently with my patients, that, Kent, when you read Dr. Sarna's book, or I read Dr. Sarna's book, it was kind of like, is this, is this mind body? Is it not mind body? But I frequently say, I think there's always a physical component, always a psychological component, always an emotional component. One of my jobs is to try to determine if there's a physical aspect that's either so overwhelming, like my hopefully not broken leg once we finish, that we need to fix it, or so dangerous, like a patient of mine who's done really well with mind body. And he called me one day and said, I've got a big lump in my throat. And I said, oh, is there anything stressful going on? I was like, yeah, my father died. And I think I literally said, we don't have to be rocket scientists to understand that metaphor, but let me take a look. And he came in and he had a big lump in his throat that I could see from across the room. And it turned out to be squamous cell cancer that he got excised and treated, and he's doing great. But it would have been irresponsible of me to say, again, like, just, an hour a day meditation and that will be great. And so we need to try to identify when there are physical aspects that we need to address. But I think what we've learned over time, or what I've learned over time, is that oftentimes those physical aspects are much smaller component of the overall picture than we would have ever imagined.
Mm-hmm. Great. Well, thank you. And I have 3 people I know who were not able to be here, but I just want to let you know they're watching the movie later. So there's definitely a lot more interest in this conversation now. So.
Okay, great. And we're recording the conversation so people can watch it later too. We'll post it to the same page where they access the movie. Thanks for your question, Fatima.
Dr. Stracks, I do have one question for you.
Yeah.
So some of I find like most difficult cases to manage, both like a pain management medication perspective and also emotional, is cancer pain. Do you work with these specific patient types or demographic to incorporate mind body into that particular pathology?
I don't have a ton in my clinic for probably a combination of reasons. I think that, one of the things, like on the fibromyalgia side, a lot of the data on fibromyalgia says that multiple interventions of a variety of types actually work better than any one major intervention. And I think cancer pain is probably similar. And so you wouldn't necessarily want to try to treat it just from this side. You want to have the medications or injections or blocks or whatever's being done. I think cancer is such a vulnerable time period. And so this type of treatment takes some insight and reflection in ways that people may not have the time to devote as they're going through treatment. I would say that when I was at Northwestern, the pain nurse in the oncology department definitely would offer these types of treatments, talk with people about sort of this connection. I don't know that she got a ton of takers, probably for that reason. Everybody's so focused on the treatment and getting through it. But clearly there's a huge anxiety, worry, fear, mortality component to it. And so we know the brain is working on that plane as people are doing this. And I think, an individual here, an individual there, may be able to start to incorporate this as part of what they're doing. I think if we really want to systematize it, it would take a lot of conversation of a lot of parties to try to make that happen.
Great. Let's talk a little bit about a type of pain that can be really tricky, which is back pain. So I want to put this study that was recently done in the chat. I think it's a study that's really worth looking at and reading. Is one that Howard Schubiner and a bunch of other of John Stracks' colleagues were part of, published in JAMA Psychiatry, about pain reprocessing therapy for people with chronic back pain. And it speaks a little bit to Fatima's question about the prevalence of mind-body back pain. Like, are we talking 2 to 3% of people with back pain, or are we talking a lot more people? Because they cite an idea in this study, they cite another study in this study that 85% of back pain has no peripheral etiology, meaning like there's no like clearly identifiable cancer or infection or an extreme herniation that has findings in the leg of muscle movement issues. And so they say 85% has no clear structural cause. So then there's a question. So what percent of people without a clear structural cause have a mind-body or a type of back pain that has a response to a mind-body treatment. And so they randomize people, and the people who go through a similar treatment that you see in the film with some small differences called pain reprocessing therapy, there's 66% of them become pain-free or nearly pain-free, so 0 or 1 on the 10 on the pain scale. And so it's a pretty phenomenal result, and it really made a lot of waves when it came out. And Alan Gordon, who's a social worker, was a big part of the twice-a-week therapy that people do for 4 weeks. And a lot of it is around fear, changing your relationship to fear. But another big component of it, just like you see in the film, is changing your attribution of what's causing your pain. So is your pain caused by an injury to your back from your car wreck from 5 years ago? Or is your pain caused by a neural pathway, a learned process in your nervous system that's reversible? Or is it caused by stress? And what they showed is the people in the study who had the biggest drop in pain were people who changed their belief the most as to what was causing their pain, whether they believed it was an injury or if they believed it was neural pathways. And I thought that was a really fascinating finding. And I'm sure you're familiar with the study, Dr. Stracks. And did that make you think differently about the prevalence of mind-body, mind-body syndrome or mind-body causes of pain, or what do you make of that?
It was an outstanding study, clearly. And in addition to the clinical benefits that people got, they were doing real-time brain MRI studies as well, and showed substantial changes in people's brain activity before and after the intervention. And so they really are changing people's physiology with that kind of intervention. I think from my standpoint, I see a lot of people with back pain, a lot of people with musculoskeletal issues. Again, like I'm sort of, for a whole variety of reasons, perfectly comfortable talking with people about the non-physical contributions of that. I think it's a fantastic addition to the literature to have it both the fantastic clinical outcomes they had plus the fMRIs that they did. And so, as you said, Kent, we're super excited that that study got done and got out there. Dr. Koushik, they're USC people who did that study. Do you know them? Have you met them at all?
Not that I know of. I haven't actually read this entire paper as well. I'm not entirely sure, to be honest.
Yeah. We should make those connections because Alan Gordon, who's the director of the Pain Psychology Center in Los Angeles, he's a USC social work grad, and they tend to get interns from Keck in their office. And so a lot of those people have trained at USC. And if you're thinking about, implementing something within your center, there's some work being done in other aspects of the institution. I think they're mostly private. Like I don't think they work under the aspects of USC, but I think several of them have some connection. So we should try to push on that a little bit.
Is that, Dr. Stracks, is that an important part when somebody comes in with back pain? How do you do you spend time differentiating what's going on, and how do you approach that?
Yeah, I think, you read Dr. Sarno's book. I read Dr. Sarno's book. So he was a physiatrist in New York City, 1960s, 1970s, 1980s. And so a long time ago. But, one of the things he always said is he didn't consider himself a practitioner. I don't consider myself a practitioner in alternative medicine. I try to be a practitioner in good medicine. And so I am spending time with people, getting to know them, listening for the history, listening for the pattern of the pain, doing a physical exam if they're there in my office. That's a little bit less common now with COVID and telehealth, but really looking for any reason that I think that there could be a major physical issue. A lot of people come to me having had multiple MRIs, sometimes multiple surgeries or interventions. And so I'm just trying to do what I think any good physician should do, which is to get a sense of what's going on, that's the underlying issue, and what can we do to address it. And I like to say that I'd like people to feel better, and I'm pretty agnostic about how people get better. And so if people need a procedure or injection and that's what's going to make them better, I'm all for that. I see a lot of people who tried a lot of that and haven't gotten better, or they can't do that because nothing's wrong on their exams or MRIs. So I'm working my hardest to try to get a really good sense of what's going on underneath the surface, and approaching it from the root level, and trying to help people that way.
That's really great. Dr. Koushik, do you work with people who have like head pain and migraines? I'd like to talk a little bit about that with the group. Like, what are the best ways to help people with those kinds of issues?
So for me, I am, but typically they usually see a neurologist or a headache specialist. The neurologist refers them to me for a very specific intervention, which is Botox for migraines. So that's kind of the majority of our migraine practice. But I do see patients who they come to me incidentally as their first kind of entry into the USC system,
right?
Complaining of headaches that have been worked up completely, that they've had for years, and they're kind of trying to figure out how to manage them. And they've tried opioids, which are not even recommended for this, in addition to many types of neuropathic medications. So I do see migraine patient population. It's usually for Botox, which actually ends up working fairly well. But I do have a subset of patients who I end up referring out to a neurologist for, just because it's kind of more in their scope of practice.
Kent, next year's headache fellow at Harvard started out this way. She had migraines that were so bad she was in bed for 5 years and used these strategies to get better. So she'll be Harvard's headache fellow next year.
Wow, nice. Is there? I feel like I've heard Howard talk about how he's like 2 to 3% of people with migraines or head pain have like a structural disease process or a cancer or a tumor, something that's directly causing it. And then he would imply like, therefore the rest of them should be assessed for mind-body issues. What are your views on migraines and how to assess people, Dr. Stracks?
Yeah, and just Elizabeth's got a question too.
Oh, thank you.
Get to her in a second, but
I'll get to that next.
Sorry, this is the question is coming from Dr. Gross, who's one of our pain psychologists at USC.
Mm-hmm.
So we work very closely together. We can either question now or after.
Yeah, we can do it now. Great.
Yeah, we'll come back to the migraines later.
Yeah, please unmute yourself, and I'm asking.
Yeah, it's not so much that I have a question. I'm, as Dr. Koushik said, I'm fortunate to be part of the pain center at USC, and there definitely is a coordination and a respect for the part that psychology plays in chronic pain, and we work well with occupational therapy and physical therapy as well. One of the things that I find as a challenge is that patients that are referred to me tend to be able to accept the part that emotions and trauma history and stress in their lives plays in their chronic pain condition, and can see how pain exacerbates the stress. And oftentimes they can see how new stressors can impact and increase pain. The problem that I struggle with oftentimes is the connection, the causal piece, the other way around. For me as a psychologist, it's very important that I'm not kind of overstepping and not saying that, this is the cause of it. And so that's where I find the challenge. And it was very interesting in the film, which was very well done, by the way, that, there was so much time taken to rule out, a physical cause. And I find working at the medical center that there are so many different subspecialties. There's rheumatology, there's oncology, all the ologies that all have their say. And there's potential for one of these subspecialties finding a new thing that could possibly speak to this new pain that's developed. So it's always a challenge for me as a psychologist to kind of stay in my lane and make sure that I'm playing a supportive role, but not saying that this is the cause of your pain. And I don't know if you can maybe speak to that a little bit, and how to work as part of that team in that regard.
I think I mean, I ran into the same issue when I was at Northwestern. This was maybe 2% of my practice, and there's an app that we've been working on developing called Curable. Some of you may use it. Hopefully, I can say brand names in here, but and then I'll come back to that in just a second. But I did a podcast with them in 2017 as I was opening my own practice, and I said, you know, I've been here for 8 years. It's a very small percentage. I'm just not sure that the demand is here for this kind of treatment. As soon as I left, like literally within 3 weeks, it was 20% of what I was doing. We built that up to probably 50% of what I'm doing at this point. And so I think the energy of the big medical system is about big medicine. Like it's, you know, that's what the hospital system does. And so I do think that frequently the psychology is the cause of people's pain. I think that people who really understand that nicely, it gives them a very nice pathway forward in a way that it doesn't if you think that the psychology is just contributing to the pain or worsening the pain. And so I've got a patient who's done spectacularly well with fibromyalgia, who was always frustrated by that nobody would tell him that he could get rid of the pain until he encountered this. I bring up the app and what can be done to say that 10 years ago, 12 years ago, I guess, Dr. Schubener and I invited everybody we could find in this field to Ann Arbor for a day of sharing ideas and giving talks. And like 30 or 32 people from around the country came, which was great. The Curable app has a clinician arm to it. They opened a Facebook page. There's like 3,000 clinicians who are interested. And so it's 100 times easier to enter into now than it was 10 years ago. And so we just keep chipping away and having conversations and individual conversations. And 10 years later, it's 100 times more common. And so that is my hope to it, that yes, in any one encounter, you may encounter a physician who says, like, don't tell my patient that it's in their head. But that like we keep having these conversations, we keep having these events, and we keep making these movies, and it grows and people can tap into it. And the hope is that ultimately people will say to those physicians, like, I don't want your intervention. Let me talk to Elizabeth.
Well, they might be doing both, which is good. I think it's a good collaboration.
Yeah.
Great. Yeah. Well, so we're getting close to wrapping up. There's time for maybe one more question. If anybody has a burning question, now's the time to ask it. I'll leave a pause there. Oh, wait, we have, okay, Fatima, yeah, go for it.
I think I have one. I'll try to be succinct. I like, it was what Dr. Stracks, you said, I am agnostic about how people get well. And I really like that. And then it just sort of like reminded me that when it comes to this field, for me, there's like two domains. There's a like peer-reviewed empirical evidence around what we're doing. And there's a lot of people out there who seems to be also very acclaimed, like, you know, medical medium healers and, you know, like documentaries like Hill and like New York Times bestsellers, yet their work isn't peer-reviewed. However, it seems to have a huge benefit out there for people. So I guess it's just sort of like the question is there room, because I am more of an academic person that's driven by peer-reviewed empirical, you know, type of evidence practice in medicine. But like at this point, when we talk about mind body and what the research that we've been doing, I believe is the tools we have are more Newtonian-like tools for like, you know, looking and dissecting the body more so that looking at the mind, which is for me more of a quantum thing, really. Like, is there room to like bridge, you know, sort of like our like where we come from, which is like more what's the word here, like just really empirical evidence-based versus like there are a lot of also like more, not even anecdotes, just like people that do the work out there in this field of mind body that don't have peer-reviewed work that does help a lot of millions of people out there.
I'm just going to take a quick stab at this.
Please.
One thing, so I think that the whole medical community it's kind of tends to be more procedural. Part of this may have to do with the financial benefit of it and the way, trying to identify a physical cause that can be treated with a procedure is sort of how the training has been from the beginning.
Yeah.
So I think you're right. In order to get widespread acceptance, you really do have to have randomized controlled trials that are double-blinded or head-to-head. But I think maybe trying these types of studies against traditional medical therapy with opiates and injections and procedures may be what is necessary in order to kind of push this agenda forward. But the other thing is that I think in terms of just the time, I think that some of these visits, I think Dr. Stracks, you had commented on, you have the benefit of time. And I think a lot of people in the medical system don't have that benefit when you're seeing 6 patients every hour. So I think basically my big point is I think this may have to do a little bit with reimbursement, and the reimbursement scheme may need to, from Medicare, may need to involve time as a priority versus a procedure.
Yeah.
Yeah, and I
And
just wanted to
on
make,
that-
go ahead, Doug.
Sorry, I was just on the aspect of time. Like, I don't know if there are any students in the audience, but that's one thing I remember from school is that I realized at some point in my 3rd and 4th year that the one asset I had as a student was time that nobody else did. And spending that time allowed me to hear a lot of stories of what people wanted to say and didn't have anybody to tell them. And so if there are students out there wondering, like, what's my role? Like, that time is a great commodity in the medical system, and students have more of it than anybody else does.
And I just wanted to add too, those are great points, that Fatima, there is good evidence-based now research, peer-reviewed, double-blinded, or randomized controlled trials, like we mentioned the JAMA Psychiatry study, which is really, really done at a high scientific level at the University of Colorado at Boulder at this neuroscience lab. And then there was the fibromyalgia study that was done that's referenced at the end of the film, which was published in Pain, which is a peer-reviewed journal. So you're totally right that there are all these modalities. There's so many different treatments, and every treatment's going to have people who say it worked for them. But medicine is based on data, and and doctors are encouraged to go by evidence-based therapies. And so this one is one. It's one that has a lot of anecdote. Obviously, I'm an anecdote. Dr. Stracks is an anecdote, but it also now was officially recognized by the Department of Health and Human Services based on the power of those studies that have come out. So we're really thrilled about that. And that's only been in the last several years. For many years, it was just sort of like, I don't know, maybe it's another snake oil thing, who knows? But now there's good data. So I encourage you to check it out and get involved if you're interested. Okay,
Thank you.
Thanks.
Is anybody nervous?
Yeah.
We're literally on this together because what we're here for is to get better.
Tingling to numbness, primarily my left hand.
100 million Americans suffer from chronic pain.
This illness has taken a lot out of me, out of my family.
Just the worst pain that I've ever imagined in my life.
He's taking all these meds and he's no better than he was.
Millions of patients with pain have become opioid addicted.
We have this idea that when there's pain, there's something wrong with the body. It's not always that simple.
Hysterectomy, colostomy, ileostomy, but then the pain came back.
The brain is powerful and can cause almost any symptom imaginable. How does our life events affect our body? That's what we're going to go through today.
It terrifies me.
I can see that.
I would reject the notion that everybody with chronic pain has a psychological origin.
I don't expect Dr. Schubener to cure me.
I call BS. It's pretty succinct, to the point.
I don't know exactly what to expect.
Living in fear is the perfect prescription for back pain, migraine headaches. People can retrain their brain, and that's what I'm asking you guys to do.
I fought my whole life.
Just tore my life apart.
I'm angry and I'm sad.
This treatment is not for everybody.
Now I'm experiencing new symptoms, and so I'm freaking out.
You're stirring things up.
My shit is so stirred up.
It's amazing how something you don't even know is there has that much power over you.